Okay, I think for the sake of time, we'll probably still have a few more people joining us here. We've got 61 people on here so far, which is absolutely fabulous. Thank you very much for joining us on this managing spasticity for people living with spinal cord injury. My name is James Heckner. I work for Praxis Spinal Cord Institute as the BC Regional Community Liaison, along with my colleague Shannon Rockall, who is an occupational therapist with well over 25 years experience in spinal cord injury. Unfortunately, Shannon is a little under the weather today, so I will be primarily facilitating the meeting today, the webinar. We have two excellent experienced presenters. Rita Calero, who is a Plex person with lived experience, definitely well-versed with spasticity, so definitely interested in hearing your story, Rita, and how spasticity has impacted yourself and how you've overcome some of those challenges, of course. And Brittany Marcoux, who is a registered clinical resource educator at GF Strong, and very experienced, of course, with spasticity as well. So welcome, and thank you very much for presenting here today. We would also like to just start out with always appreciate a land acknowledgement, and Praxis Spinal Cord Institute would like to acknowledge the land on which we are hosting this webinar is on the unceded traditional territory of the Syilx Okanagan Nation. We acknowledge these beautiful lands in which we learn, work, and play. We recognize that individuals are joining us from all areas of the province, and we definitely welcome you to share your territory from where you're joining, and you can do that in the chat option. I also wanted to mention that this is actually our fifth webinar, and I will just throw in the chat here the channel where you can actually view some of the other webinars that we've hosted. These webinars are basically an expansion to the workshops that Shannon and I have been providing throughout the province. We've provided, I think there's 38 at this point throughout the province, and we have two more next week here in the Okanagan, and one actually up in Terrace coming up in October. So looking forward to that. I also wanted to just kind of start out by talking a little bit about my experiences with spasticity. I've had a spinal cord injury now for 28 years. I am a T6 AIS-A injury. I've also got a syrinx that has actually impacted a level up to C2. So some sensory function loss. But my experience is definitely, it's been extremely favorable compared to many, because there are definitely some extreme cases out there, which is some of the information that we're going to hear about today. But I definitely utilize my spasticity now, many years post-injury, starting to learn about my injury, learn about my body. And it's interesting, actually. I was just I had like a couple egg bites this morning, and I warmed them up. I put them on the plate, and I put them on the plate on my legs. They weren't hot, but they were warm. And sure enough, I got a little bit of spasm on my right side. And it's, to me, I utilize that as science. If I'm starting to get spasms, which is typically just on my right side, strangely enough, not so much on my left, it's something that I start to acknowledge that I need to address. Could be a sock or something like that. But anyways, at this point in my stage of learning how to adapt with SCI, even at 28 years, you're still learning how the body works. So I've definitely had experiences with different types of drugs and that sort of thing, but we're going to dive into that pretty deep here. So maybe what I'll do is I'll pass it over to you, Brittany, and looking forward to hearing your presentation.
Thank you, James. That was actually a great intro for what we're going to kind of talk about today. Let me just get sorted here. And James, if you can just confirm that you are seeing what you're supposed to be seeing on your end.
Looks perfect. Yep.
Okay, great. So hi, everyone. My name's Brittany. I am the Regional Clinical Resource Educator for occupational therapists, specifically with neuro and spine populations for Vancouver Coastal Health. But I have also worked with outpatient spinal cord injury at GF Strong, as well as in the Spasticity clinic for the last few years. So this is definitely a topic that I am passionate about. So really happy to be here. Please feel free to put questions in the chat box, and James will kind of review them with me at the end of the presentation. So just piggybacking off of James here, I just want to honor that I'm participating today on the occupied traditional Squamish, Musqueam, and Tsleil-Waututh territories, in which is colonially known as Vancouver. And I'm extremely grateful to be able to work, play, and learn on these unceded lands. The learning objectives for today, we kind of just want to all get on the same page as far as understanding what is spasticity, what's the definition, and how it might present itself specifically in spinal cord injuries, understand the impact of spasticity on clients, and how we as allied health can assess it, identifying therapeutic interventions for spasticity management, and then kind of looking also at that pharmaceutical side of things or surgical treatment options for spasticity management. So just to start, you may be familiar with the Lance definition. I more frequently have been using the Pandian definition, which is disordered sensory motor control resulting from an upper motor neuron lesion presenting as an intermittent or sustained involuntary activations of muscles. So what I really just want you to remember there is for true spasticity to present itself, there does need to be a CNS diagnosis. So anything affecting the brain or the spinal cord leads to the loss of that supraspinal inhibition and of inhibitory interneurons. So this results in a stretch reflex that comes on earlier and stronger than it should. So these individuals have a hard time controlling that contraction and relaxing those muscles. And James kind of brought this up perfectly. So sometimes we think as clinicians, oh, spasticity, it's always problematic, or perhaps we get called in when it starts to become problematic. But specifically with SCI clients, it can be super helpful. It can help with mobility, transfers, improving our grasp. But again, as James mentioned, it can serve as this warning sign to noxious stimuli. So again, James mentioned there was some heat on his lap. His body was recognizing that, and some spasms started to kind of warn him that, hey, this could be dangerous. And we'll talk about some aggravating factors later on, but that was a perfect example. Another thing, just as far as function goes, that I can mention, I had a client who had paraplegia over 20 years living with her injury. And she had come to a spasticity clinic because she was concerned about her plantar flexor tone. So she was having a hard time getting her heels down and positioned nicely and neutral on the foot plates. And so that caused some instability at the front of her wheelchair. And so she wanted to be assessed to see, what could we do about it. Eventually, we determined, she was appropriate for focal Botox injections or botulinum toxin injections to the plantar flexors. However, what she noticed after kind of they started to take effect, she noticed her legs felt a lot heavier. Her pivot transfers became that much harder. And what she didn't realize was she was actually using a lot of tone in her plantar flexors to pivot off of during those transfers.
So not sure where I got cut off there, but to kind of summarize this slide, spasticity can be helpful. James kind of put a perfect description of that earlier. And oftentimes clients aren't aware of how helpful spasticity can be or how they might use it functionally. So as therapists, it's important that we guide that conversation and really understand how they do tasks day to day to make sure that, if we do provide any intervention or eventually any pharmaceutical options down the road, that we are aware of their function and that we're not going to take away any function. That's kind of a number one rule, and especially important with spinal cord injury. So some predictors for severe spasticity within spinal cord injury, some neurological factors would be the level of injury. So often cervical or upper thoracic level injuries are at higher risk for severe tone. Completeness of injury, incomplete spinal cord injuries such as ASIA B, C, or D are also at higher risk. And then those that develop spasticity early on, so maybe within that first 6 months post-injury, are also at increased risk. So it's important to think about, if you're, depending on where you're receiving your client, just thinking about, what is their level? Are they complete, incomplete? And are they at higher risk maybe compared to some other populations or diagnoses, just so you can be extra aware of how we need to keep an eye out for that. Some clinical or functional factors that could impact this might look at reduced mobility or immobility. So less active individuals are more likely to develop severe spasticity due to contractures forming and kind of reduced modulation of reflexes. So again, maybe higher level injury or again, even more complete or non-ambulatory clients could be at risk. Severe muscle weakness or imbalance that contributes to exaggerated reflex activity and contractures. And then as well as pain or skin issues. So we'll talk more about this in an upcoming slide, but that nociceptive input, so, that noxious stimuli, the body is telling us that something is wrong, we don't know what, but that can trigger or worsen spasticity.
All right, Brittany, one more. Are you on slide number 6 or on slide?
Oh boy, I was on slide number 7.
Oh, there we go. I see it moving to, okay, so yeah, and then.
So you can see this okay, yeah?
Yes, where if it's clicked on, it seems to move. So, okay, sorry about that.
No, it's okay. Are you on essential components now?
On slide number 7, predictors and severe spasticity.
Okay, let's try.
There we go.
Sorry, guys.
No worries. You've been having issues the last couple of days, believe it or not. Oh,
yeah. Well, you know what? I'll leave it like this for now, even though you can kind of see the background, but at least you guys can see the slide. So perfect. We'll go with it like that. So essential components of assessment. So these are some things that we want to kind of cover when we're doing our full assessment, just to really get that kind of bird's eye view of the client and thinking about all the things that can impact spasticity, because it's quite a lot. So we'll kind of do a deeper dive now into these categories. So spasticity ultimately needs to cause a problem for us to address it either from a conservative standpoint or a pharmaceutical standpoint. Because as we've talked about, not all spasticity is bad. So just because your client has tone doesn't necessarily mean, oh, we need to address it. So the first thing we always ask clinicians is, what is the problem? And this can look, a problem is obviously super individualized to the individual, but we can also look at it from a couple different categories. So for example, is it pain? Is there difficulty with positioning? Are we losing range of motion? Is it causing skin breakdown? Or potentially, is there just really dynamic intermittent spasms and it's causing really poor sleep? I had a client come to us before saying, I'm constantly waking my partner up in the middle of the night. I really need to control these spasms because it's disrupting my sleep, it's disrupting their sleep, and this is a problem, right? Versus somebody else might say, from a cosmetic standpoint, I really don't like the way my arm looks when it's flexed and the fingers are curled. And I just want my hand to look more normal. I feel like everybody's looking at my hand. So that in and of itself is also a very valid problem for that individual, right? Poor self-esteem, poor self-image. And then you might look at this other kind of two categories, which might be active goals versus passive goals. So when I think of passive goals, I think of potentially the person is more dependent with their basic activities of daily living or their day-to-day care. And perhaps it's really challenging for their care staff to get them dressed or to do peri-care, or perhaps getting them into the chair and getting them to stay in the chair. Versus more active goals, perhaps we have, somebody who is an incomplete injury, is able to ambulate a little bit, but they're presenting with more of a scissor gait, or they are getting toe scuffing with their plantar flexor tone, or perhaps they're not able to open up their hand because their finger flexor tightness is quite significant. So that might be looking at more active goals where we're trying to get them to participate better in their day-to-day function. So there's a wide range of problems or goals when it comes to spasticity management, but the biggest thing is that it is really person dependent. And we really need to look at it from a client-centered perspective or a caregiver's perspective. So this is two examples. This is a spinal cord injury client who there was definitely some care goals or passive care goals that we were looking at. So you can see on the left-hand side, we're looking at somebody who has significant adductor tone, knee flexor tone. You can imagine positioning and peri-care was really significant. And on top of that, the pain that the client experienced during care was really, really high. So that might be a very common position that you might see. Whereas on the left-hand side, you can see the elbow is flexed and the hand is fisted. And this individual was basically stuck in this posture. So getting proper support through the forearm, hand hygiene, nail care, accessing their technology, and at high risk for losing further range of motion. So again, the priorities of these individuals was definitely more like care-related goals. However, for some, once those are addressed, you can start to look at, how might they use the limb more functionally if we can get them in a better position. We doing okay, James?
Yep.
Okay, great. So with the initial assessment, the first thing I look at would be resting posture. Ideally, if you can, it's great to get the client into supine where they're kind of at rest and you can do a full head to toe assessment. However, perhaps they're mostly in their chair and the real problems come from when they're seated. So maybe it makes more sense to assess them in the seated position as well. But it's important to comment on, what postures are you noticing at rest? What does that overall picture look like, and kind of take note of that. Then we want to look at the range of motion. So looking at passive range of motion. So is there resistance throughout the range of motion? Do they have full range of motion? Have they lost range? Or do they have the ability to do active range of motion? So what function do they potentially, or strength do they potentially have in that joint that you're assessing? So that kind of gives you an indication too of what are the barriers, the limitations, what function do they have? And that leads me into kind of that modified Ashworth scale, or how to assess spasticity. So there's two assessments you may have heard of, the modified Ashworth scale versus the Tardieu scale. I'm most familiar with the modified Ashworth scale, and I'll review it shortly. But I do also use aspects of the Tardieu scale because it really allows you to bring in more of that dynamic component versus just looking at the person in a static position. So R1, so MAS is modified Ashworth scale, that tone assessment. R1 is range 1, where that first catch of spasticity is. And then R2 is their end range. So if you're ever seeing that in documentations or you're trying to document it, you can use kind of that language. And then you might hear people talk about static versus dynamic. So static really means when the person is at rest, they're not moving. What does that tone look like versus what happens if suddenly they go to transfer? They are able to ambulate. What does that look like? Or they're doing some of their activities of daily living. Does that tone pattern or presentation change? But then it's important to note that, because sometimes I might assess a person in bed and I'm looking for spasticity and I feel nothing. And then all of a sudden I see them transfer and I can see a completely different presentation. So it's important to look at them in kind of both environments. Strength, it is helpful just so we know what spasticity is helpful versus what is their own volitional strength. So is it tone that they're using? Is it actually strength that they're using? How does their sensation impact them? Because we know that kind of motor control and sensory control can have impacts on spasticity and how it presents itself. So that's also good to keep in mind. And then mobility. How are they moving? How much independence do they have? What does that movement look like? Pain. I'm often doing a pain scale as a baseline for these individuals and getting a sense of, is it nociceptive pain? Is it neuropathic pain? Do they have pain with care? Do they have pain sitting in their chair? Where is the pain? What type of pain? And then, as I previously mentioned, how are they functionally using their spasticity or the limb that you've identified as problematic? So this is there's a lot going on here. However, this is really what gives us that comprehensive assessment, because spasticity can be so complex and can present so differently and intermittently. So it's really important to have a really good understanding of the individual and how it might affect them. So modified Ashworth scale, you may be familiar with it, you might not be, but basically it goes from 0 to 4. And 0 is kind of normal tone. So somebody who doesn't have a neurological diagnoses would have normal tone when they're kind of passively moving their limb, versus 4, on the other hand, is what we would potentially consider rigid query contracture. And in between is often where people kind of get a little bit lost, and it can be confusing. So try and bear with me as I explain this. But if we're looking at a 1, basically that is where you might feel an immediate catch and then a let go. So a quick snap of resistance, and then you can continue to move the limb throughout the remainder of the range. And when we are testing certain muscle groups, it's important so whatever the primary function of that muscle group is, so let's say you're testing elbow flexors, I would put the elbow in the elbow flexed position and then pull into extension. It's because I want to test that tight muscle and see how much it fights me, if at all. So again, whatever the primary function of that muscle group is, you want to start the joint in that position and then pull it into the opposite direction. 1+, you're looking at that catch, and then you're going to feel a slight increase in resistance throughout the remainder of the range of motion. So it's not a let go like the mass 1 was. It's there is tone throughout the remainder of the range. And usually when we're talking about a 1+, less than half of the range available has tone. So it wouldn't be kind of the full range. It's kind of less than half of the range available has tone. And that's where it kind of differs between modified Ashworth 2 is now we're looking at more than half of the range available has resistance. So there's a more obvious marked increase in tone throughout that range, but you still can move the limb. And then modified Ashworth 3, I would call this like the grunt test, or, you know, breaking a sweat, where you are grunting or breaking a sweat to move that joint. So it is significant tone, considerable increase in tone. Passive movement is quite difficult. So that was what I would label as a modified Ashworth 3. And then, as I mentioned, 4 is rigid. And, you know, we're wondering, is it contracted at that point? So I kind of alluded to this earlier, and James did as well, but there's some aggravating factors when it comes to spasticity, and this is especially prevalent in spinal cord injury, where there's certain things that can make spasticity worse. So pain or discomfort, bad bowels. So, you know, asking the client, what is your bowel routine? Are you fully emptying your bowels? Are you having any incontinence or unplanned bowel movements? Is the stool super soft, or is it quite firm? That can be a really big trigger for individuals. Also looking at infections or illness, you know, are they sick? Do they have a UTI? Do they have any current pressure sores or pressure sores forming? Any ingrown toenails, tight clothing, poor postural management. So often I see seating as a big component to making spasticity worse. And then, are there any new injuries, and do they even know if they've been injured? So a lot of the time, obviously, with our spinal cord clients who have reduced sensation, this can be an area where we really have to investigate and kind of go through this list of questions. If they come to you and they say, oh, all of a sudden my spasticity is so much worse this week, I don't know why, it hasn't been this bad before, but it's really, really bad. That to me is like a moment where alarm bells should be going off to say, like, okay, something is triggering the spasticity and we need to figure out what it is, because it is not normal for a client to have kind of somewhat stable spasticity and then all of a sudden it get kind of worse out of the blue. So it's really important to kind of ask these questions, and perhaps we'll hear like more from Brita too, if she has any experience with this. Brita, did you want to pop on?
Sure, yeah. So I do, someone said in the chat, does stress trigger it? I think for me, I do notice, James, I don't know if you do. I notice it if I'm in meetings sometimes. I work in a school setting and sometimes there's conflictual things going on in the meetings. So I do notice I'll get more spasticity in that setting.
Absolutely.
Yeah.
If you're sitting in one spot for sure for too long, you start to get stiff and spasms for sure. Yeah, I find exercise definitely helps.
Mm-hmm. Yeah, that movement piece, and Brita, exactly. I've heard that before too, is I've had clients who had to do presentations for work, or, maybe some changes in their personal life are going on, and that just ramps up that spasticity, for sure. I'm just going to try doing, oh, sorry, go ahead, Brita.
No, I just wondered if you wanted me to say more than that, or is that good enough for now?
That's great. I'll hurry along here just because I know we're tight for time. And then, perhaps you can expand more about it. I'm just going to see if this works, James. Are you on therapeutic treatment options?
Still on aggravating factors.
All right. Never mind. I will go back. Yeah, I'll go back. Okay. So we have kind of done our assessment, looked at the range of motion, identified the problems, resolved any aggravating factors if we identified them. We have our kind of baseline outcome measures. We know what the client's goals are. And so now it's kind of like, what do we do with that information, right? So from an OTPT perspective, so there's lots of different things that we can do to try and address the spasticity. One of the big ones that is a part of my practice would definitely be education about spasticity to the client or the caregiver, because it ultimately helps them self-manage and understand really what it means and what's going on. So education might mean, moving the limb slowly during care versus quickly, because we know spasticity is velocity dependent. Perhaps reducing triggers like cold. So if they are getting kind of washed down with a wipe or a cloth, making sure it's warm water, not cold water, because we all tense up when we feel cold. Or recognizing, perhaps I know that stress is a big trigger of mine. So how do I minimize that? Or looking at, okay, I know if I'm getting increase in spasticity, sometimes that might mean I have a UTI that's kind of starting. And so I need to kind of address that piece. And so just giving them the tools and the toolkits that, they can investigate and know, what things make it worse, what things make it better, and can hopefully kind of manage it a little bit on their own without always requiring kind of a healthcare professional there. 24-hour postural management. I will get into this a little bit next, but looking at what does their bed positioning look like? What does their chair positioning look like? This postural management piece is probably my biggest intervention that I provide when it comes to clients, because it can be so impactful and make a really big difference. Especially, clients aren't always going to have OTPT there. They're not always going to have caregivers there. They might not be able to do their own exercise or range of motion home exercise program. And so what can we do from a bed positioning or a chair positioning standpoint that can optimize positioning or put them in a position that kind of dampens that spasticity? So that can be one of the more effective things for sure. James mentioned, exercising really helps his spasticity, stretching, bracing, splinting. All of this can be super helpful. I find it's really person dependent, and it really changes depending on the level of tone that they might have. The thing to remember is that, if the person isn't able to stretch, at least once a day or multiple times a day, it might be hard to maintain like optimal function or maintain their range of motion if they are then reverting back to a spastic position for the other 23 hours a day. So again, it's for some people, it really works and they don't mind wearing, a splint all night, or they do have 24-hour care where this might be a little bit more reasonable, or they have private therapy. But for some individuals, it might just not be realistic. So then we need to look at other more sustainable, realistic ways to manage. And then I talk about task-specific training. So really showing the individual how they can use their tone or things that they can do to optimize their function with the tone that they have. If your agonist has spasticity, can we strengthen the antagonist to kind of balance out that current muscle imbalance? I often see that sometimes with FES or NMES, trying to kind of restore that balance. TENS can also be used. But again, the research shows that it's more like short-term effects versus long-lasting effects. And then adaptations. So for some clients, perhaps if they're in like long-term care facilities, maybe looking at adaptive clothing to meet those passive care goals, or kind of adaptive aids might be kind of the more sustainable and realistic way to go, depending, maybe they live in a more rural area versus an urban area, and getting treatment more frequently is challenging. So I think we always have to consider what is realistic and sustainable for our client as well. So this is one of my previous clients. They were originally seated in this position. You can see that, especially in the right picture, scoliosis, convex to the right, pelvic obliquity, knees are coming together, adductor tone, and then what you can't really tell in this photo but see is that they also had internal rotator shoulder tone. So those arms were kind of an adductor tone. So arms were kind of clamped beside the body. And it was very difficult to position those arms on the armrests. And you can see kind of plantar flexion posturing too in the ankles as well. So lots of wounds forming, significant spasms, really, really challenging. Ultimately, this individual received as much kind of pharmaceutical intervention as they could when it came to botulinum and toxin injections. But ultimately, there wasn't enough to go around because their tone was so significant. So you can see from my note there, the level was C4 Asia B. So again, indicator for severe spasticity, cervical level incomplete. So we did, one of the things thought about was like, okay, what else can we do besides medication management? And that was positioning. So we completed a seating assessment. We looked at what is kind of the optimal position for this individual, where suddenly we feel them relax a little bit, or they're able to kind of maintain a nice position for a prolonged period of time. They feel stable, they feel comfortable, and we see that spasticity has kind of calmed down a little bit, versus in the previous slide here, this client was constantly shooting out into extensor spasm, likely because he was positioned in an extremely extended and opened position. So we kind of got him more into that upright 90-degree position, and it was way easier to be able to manipulate his pelvis and his trunk after we kind of found a way to reduce that extensor spasm. So I would say his seating was the most effective intervention for spasticity management, but then he had in conjunction with pharmaceutical treatment, and that seemed to ultimately work the best. And then we also kind of looked at bed positioning as well. So it is an important thing to think about how the seating system can really make a difference for the individual. Bed positioning. So on the left-hand side, one of the interventions that we did here, this client had posturing of flexed elbow and internally rotated, where it was resting on their stomach, and was starting to get some tightness, not from spasticity, but just from lack of movement into the hand. So one thing we did was, again, we kind of wrapped that pillow around the arm so we could create some space between the trunk and the upper limb to not allow such a adducted, internally rotated position of the shoulder. And then almost created like a little trough with the pillow to hold that elbow into extension or stretch it out a little bit, and then applied the resting hand splint. So again, this is a very easy thing to implement. The client was comfortable, skin health was maintained, and because the tone was not as significant, the client was able to maintain this position. They didn't spasm back into an elbow flex position once that pillow was kind of blocking them. Versus on the right-hand side, you can see knee flexor tone, wind sweeping, positioning with the lower extremities in bed were really challenging. They actually had shortening at the knees there, so we couldn't get them into full extension. So when this happens, obviously we know heels and feet are at risk for skin breakdown, worsening of contractures or shortening at the joints puts them at risk, and often it's quite uncomfortable as well. So with this, we want to think about, okay, how do we at least maintain the range that they have? Can we get their pelvis more neutral? And so you might want to start to look at wedges or, supporting the hips into a more neutral position, not allowing maybe that left leg to externally rotate so much, and making sure, that the heels either are resting on a good surface for skin management, or looking at potentially offloading if they're at high risk. So again, I think the conjunctive therapy, as far as like the conservative treatments that OT and PT can provide, can be the most impactful, but then we can bring in that pharmaceutical treatment to fully achieve that goal, or to help us with our conjunctive treatments. So often them going hand in hand can be super effective. Other positioning items that we can use. So on the far left-hand side here, we have what's called a turtle brace. Basically, it's thermoplastic, but with a neoprene covering and a zipper, and it can be remolded multiple times. Very similar to a cast in what you see in the middle there. However, what we've been doing more recently is univalving our casts and applying straps. So more of a splint cast style brace where it can be removed, skin checks can be done, the client isn't stuck with a serial cast for multiple days, but that circumferential pressure redistribution can be super effective in holding the position that we're trying to achieve, and obviously spreads the pressure off over a greater surface area versus potentially just a thermoplastic slab along the medial aspect of the elbow. And then you'll see on the right-hand side, unique splint. So this individual was posturing into a lumbrical plus position. And so we were trying to stretch out their lumbricals, or their MCPs actually, into extension, but then get some flexion, gradual flexion at the PIPs and the DIPs. So some, we might think about, resting hand splints for kind of all spastic hands, but they're so individualized and the presentation might look really different. So we just really have to know what the goals are and what the problematic areas are, and then sometimes be creative about how we might address that. And then the same thing for the lower limb. I find with spinal cord injury, stretching the ankles is particularly challenging, because oftentimes the individuals might not have the hand function or the trunk balance, or the stamina to potentially passively stretch their ankles, especially in bed. And so getting them into a standing frame, if the physician approves it and they're safe to do so, can be really, really effective as far as weight bearing through the ankles to get that stretch. So definitely something to think about is, how do we promote weight bearing through the ankles if we are starting to get tight, or if that's not a possibility, they don't have access or it's not safe due to bone density concerns, we can look at other bracing options. So for our potential ambulators in the bottom right-hand side, you might see the malleolock brace on the far right, which shows or kind of prevents inversion of the ankle. We have the dictus brace beside it, which helps pick up the foot. So potentially they might have a bit of plantar flexor tone, or maybe they just have weakness into the foot pickup. That works as well. And then you have your AFOs above, which kind of range in how supportive they can be. And then in the middle there, similar to the elbow cast you saw earlier, this is what an ankle cast might look like. And we use this a lot for bed positioning. And it's particularly helpful for controlling of inversion and kind of plantar flexion. So worsening of plantar flexion contractures or inversion. I'm sure, we might have all experienced a time where we're trying to control for the ankle or brace the ankle, but they keep popping out of the commercial brace because they have so much inversion, or they start getting pressure injuries because, they can't statically rest in this commercial splint. So the more circumferential brace can often be quite helpful. But you can also look at even just propping pillows at the end of their bed if they have a footboard or something, and just propping the ankles up into more neutral position versus kind of having those ballerina feet at rest, all throughout the night. So there's obviously a range of how informal to formal you can go with these positioning ideas, but it's all something to consider. So we've kind of looked at, the assessment, different OTPT interventions that we can do. And we also really want to be considerate and thoughtful about the goals that we're setting with our client. And so thinking about, are they experiencing pain? Well, perhaps, we're not going to address their neuropathic pain, but if it's pain with care due to muscle tightness, reducing it by 50% might be a very appropriate goal. So having an outcome measure of, okay, what is your pain currently at out of 10? All right, the goal is to reduce that by 50%. Or we want to reduce spasms during the night and prevent, frequent wake-ups of you or your partner. We might want to prevent worsening of deformity or improve range of motion. So being really specific with your goals, like almost setting those SMART goals, so that if we do start to provide intervention, whether it's conservative or pharmaceutical, we can really tell, is the intervention working? Or, are they continuing to lose range based on your measurements? Has the pain changed at all? Does the caregiver kind of report that care has gotten easier or hasn't gotten it easier? How do we score that? So just being really aware of, the different categories of goals that we can look at, and then making sure that we can easily reassess to determine, are the goals being met or are they not when it comes to providing that intervention. So that's something that I would be really clear on with, either documentation or discussing, what are some realistic goals with your client, or if you're submitting referrals, what does that look like? So let's say, you optimize their chair positioning, you provide a home exercise program, and you've addressed potentially the brewing wound that they had and addressed that aggravating factor, and the goals were achieved, then that's fantastic. But unfortunately, it's not that easy usually. So if the goals aren't achieved, or potentially the spasticity is just too severe for you to even be able to implement an effective treatment, that is a good time to look at referring to physiatry for consideration of medications, botulinum toxin injections, or surgery. So we'll kind of go there next. James, is there any kind of pop out questions that I should address before moving on?
Not at the moment. The only one that I see is, are there in the moment strategies when feeling stressed that you have found helpful to relax tone? So the only thing I can think of that I do is a deep breathing exercise. I find that my body is, in tone. I just try and just calm the body down a little bit. How about you, Breda?
Yeah, I said movement, so I'll move out of that position like as quickly. I just noticed that I do that when I get a spasm. I'll move as much as I can, and then I said breathing, and then I think I'm developing those coping strategies. I'm not as far along as you, James. Not as much of a seasoned, but yeah, just slowing the body down, right? Maybe it's going to take a bit too, right? Like I am in a stressful meeting, and so I'm going to have to just make it through and then take a few minutes to myself after that.
Yeah, definitely. I think that breathing kind of meditation, and even if you have to like give yourself a break from whatever you're doing to kind of calm yourself back down, that is probably the most effective. And if you have like a more functional limb, maybe your right hand works a little bit better than your left, potentially even just providing some gentle stretching, let's say of the hand if it's posturing, to try and relax it a little bit more or lengthen kind of it back into kind of that extended position. But it can be super challenging. So now we'll kind of jump into the pharmaceutical options. And so there's oral medications that often physiatrists or physicians might prescribe, some that might ring a bell are baclofen, tizanidine, dantrolene, etc. And that kind of affects the person globally. So the thing to remember is that it will globally weaken the individual. And like a lot of medications, some can have some negative side effects. So really looking at the sedating side effects of it, how is it impacting you or your client, and making sure you're giving that feedback to the doctor as well, because it might not work for everybody, or perhaps the dose needs to be optimized. So sometimes if you're a clinician and you're receiving a client, and you're wondering do they have problematic spasticity, it might be helpful to look at their medication list and see, are any of these on that list? If so, they likely have spasticity, and they're trying to manage it at that point in time. Other things we'll go more deep into next will be botulinum toxin. There is also another injection called phenol, which is used for focal spasticity, so problematic muscle groups. And this is really kind of an alcohol substance which causes neurolysis, so a breakdown of the nerve where they can't send those strong signals to the muscle to contract. This is a longer lasting injection, about 6 to 9 months. But often used more on kind of dependent individuals where they wouldn't be looking to use that muscle functionally, because it is breaking down the nerve and has it's not permanent, but definitely a more significant long-lasting effect. Diagnostic nerve blocks. So with lidocaine, you might have had this if you ever got dental work done. It freezes kind of the muscles for about 4 hours. They're, again, doing it at the site of the nerve. And this is one sure way to kind of determine, is it contracture or is it just really significant spasticity? So often prior to phenol or prior to surgery, and an individual might look to get a nerve block to give the doctor a good indication of like, okay, what's going on here, or do they like this weakening effect enough to go through with surgery? And then what I see most frequently would be a combination of oral medications and injections, but we'll kind of get into this next. So what are the aims of botulinum and toxin injections? You'll hear me, there's 3 brands of botulinum toxin that we kind of use locally. So Botox, Dysport, and Xeomin. The hospital systems only use Botox, so that might be why you're more familiar with it. But there are different brands, but for this presentation, I'll be using botulinum toxin. So really it's looking to optimize the effective treatments. So again, optimizing what treatments you might already be implementing to look at maintaining or improving range of motion, to improve or enable tasks, looking at allowing the individual to engage in a more functional way, reducing pain or improving posture. So again, similar to the goals we talked about earlier, there could be a number of different reasons that, you're considered for botulinum toxin injections. But really it's looking to optimize the effectiveness of maybe some more conservative treatments. So the advantages of botulinum toxin, they're localized. So rather than having that global effect of the oral medications, we're really able to zero in on what are the problematic muscles that this individual is battling. It's like, it's not permanent. So it will wear off after 3 months. And I'll go into that a little bit more on the next slide. Very few systemic side effects. And it's individualized. So depending on the person's goal, the significance and tone that they have, the physician can be really specific about how high the dose is, how many muscle groups are targeted, etc. So the effect can begin as early as day 3. We usually start to see the effect around the 7 to 10 day mark, and then peak effect hitting around that 4 to 6 week mark. So it is a good time for you to reassess your goals with the client around that peak effect, because that will really tell us, was the protocol sufficient? What are they too weak now and they've lost function, or did they really not notice that big of a difference and they would actually benefit from an increased dose? And then at that 12-week or kind of 3 to 4 month mark, if they are benefiting from these toxin injections, they would then look at potentially getting repeat injections. Some people will say, oh, I felt my muscles relaxing immediately once they get the toxin injections. That usually is just from the needle poke, kind of like a IMS effect. But the earliest we would see it could be day 3, but usually that 7 to 10 day mark. And another one that you might be familiar with or unfamiliar with, a surgical procedure, would be the intrathecal baclofen pump. So when spasticity isn't really being able to be managed by, let's say, oral medications, focal injections, it's, impacting significant, like your lower limbs significantly. One might be considered for a baclofen pump. And again, that is a surgical procedure where a pump is inserted kind of in your tummy area with a catheter running up into your intrathecal space of the spine. And it's releasing a consistent dose, kind of 24 hours a day of baclofen. However, it doesn't give you that sedating effect like the oral medications does, because it's acting directly on the spine, not on the brain. One thing to know is that the general area in which the catheter is inserted is usually between like T5 to T9. We not like locally anyways, they don't often go higher just because you can kind of get into more problematic muscle groups around the diaphragm and things like that. But so it is often targeting mostly kind of trunk to lower limb versus upper limb spasticity. However, some people have noted that once their lower limbs kind of calm down from a spasticity management, they kind of get that global effect where the rest of their body is able to relax as well. And I think Brita can talk a little bit more about that next. And the last thing, or one of the last things, is there is also surgical options for spasticity management. So you might have heard of hyperselective neurectomies, tendon or muscle lengthening, fusions, tendon transfers. So if your client is wondering, or you're thinking, oh, well, they're contracted, toxin injections aren't going to work, oral medications aren't going to work, but it's quite problematic for them, they can be reviewed by a surgeon to look at other options. So whether it is nicking some of the nerve fascicles that are innervating the problematic muscle groups to kind of dampen the overall input to that muscle group, that's an option. Versus, yes, they are contracted and now they need lengthening or releases, let's say at the hamstrings. It's obviously permanent, a longer lasting effect. Sometimes it allows people to then utilize focal injections elsewhere, whereas before they weren't, because maybe they had maxed out on their total dose. But it's important that OTPT and nursing are obviously involved for kind of pre and post-surgery setup, because that person's function might change in the interim while they're healing from that surgery. And so there might be some problem solving that has to go on, especially for our clients that have been living with spinal cord injury for so long. They've really found a way to utilize kind of their tone or the motor recovery that they have for all of their day-to-day function. So that might change a little bit and needs to be worked on as a team. This is just an example of a surgical client. So you might recognize the photo from earlier. This individual, that was his end range of motion at the elbow flexor. So he couldn't go any more into extension, and he had a fisted hand. He had a hyperselective neurectomy to the musculocutaneous nerve, as well as lengthening at the thumb and the finger flexors. So you can see on the right-hand side, his resting posture. Now he's actually able to contact the armrests. And you can see in the middle picture there, the hand is much more open. And so hand hygiene, nail care, things like that was much, much better. The interesting thing that we had to problem solve is you can see on the left picture, he was using his 5th MCP knuckle to touch his phone and navigate his phone. And we got rid of that in surgery. He didn't have that anymore. So we had to kind of come up with a new way that he would access his phone now, because he didn't have that kind of pointy area. So a lot of things that, we don't anticipate sometimes come up after these interventions as well. So we just have to, give information to the client, set expectations, but also be ready to problem solve after the fact. Some spasticity clinics in the BC area, if you're not familiar, there's one at GF Strong, Lionsgate Hospital, New Westminster Rehab Medicine, and then on the island, there is one as well. And then there's quite a few physiatrists that are currently going into long-term care facilities that kind of run mini spasticity clinics as well. So this is for more outpatients, but obviously in hospital, often you can refer to a physiatrist as well to look at tone management or query of spasticity management. Every clinic might have a different kind of criteria for who they take as a client, but it's just good to know that those options are out there. You guys will have the slide deck, but here's just some research articles on kind of botulinum toxin and adjunctive treatments. And 2:10, somehow we made it. That's it. Please let me know, James, if there's any questions.
Thank you very much, Brittany. That was excellent. I learned a ton too. I mean, geez, you always learn something new. So, no, thank you very much. And yeah, I'm sure that Rita, you have a lot of comments and lived experience. So pass it over to you. Thanks again, Brittany.
There was a question here about TENS, how much success, James, we've had with TENS, or maybe for you, Brittany. I personally didn't have a lot of success with it. I did try. I don't know if TENS and E-stim are different, but I think I tried both. And when my pre-pump, I didn't notice a change.
Yeah. James, did you have any thoughts on that before I jump in?
No, I've never tried that. My experience is actually the opposite. I would actually prefer to have more spasms than let them have. So it, for muscle, for a little bit more muscle tone, potentially bone density. I'm not sure if that would actually help, but yeah, it's interesting how it's kind of around the other way for me. So
Yeah.
Yeah, I would say there's a select group that I find it super helpful or kind of worth the time that it takes to kind of do the setup, have the machine on, things like that. And so I found sometimes like post-surgery or in the middle of peak effect of botulinum and toxin, you might see a better effect. But again, it is short-lived. So, you might get, whether it's an hour, a couple hours of good function post use of TENS, but unfortunately it doesn't, from, my experience anyways, it might not give you like a full day of that effect or, linger on to the next day or things like that. So I think it really depends kind of the capacity that you have to use it. Does it make sense for your client? Do they notice a good impact? Do they enjoy it? But it might require a lot of like input or time or effort versus the payback that you get. So that's something that's super individualized, and you got to weigh the pros and cons.
Okay, James, do you want me to talk a bit about what my experience was now?
absolutely, yeah.
Okay.
Thank you guys. I'm going to pop off.
Goodbye, Brittany.
Thanks so much.
See you. Thank you very much.
All right, so my name is Brita Calero, and my injury is a T56 B. So when I was listening to her say all the high risk factors, I'm like, oh yeah, I was in all those. I also had a right brachial plexus shoulder injury from the same accident that was pretty severe as well. I was injured in 2021, so I'm just coming up on 5 years. And I'm looking at the chat here, so as I'm talking, if you have questions, I'm happy to address them as I go, because it's really for your learning, so I don't need to kind of talk too long. So I was injured in 2021 in January, and about a year later, I did have spasticity leaving rehab, and I was on baclofen. But about a year later, it worsened to where I thought, okay, something's going on, because people tell you something's going on when your spasticity worsens. So I was trying to look into that, trying to figure out what was going on. And it just basically, my baseline tone shifted to the point where I needed to sleep with my legs in butterfly, because as soon as my legs would get extended, my whole body would contract up to my T5, like a full clench at every stimulus. So in bed, when a sheet would come across my legs, my husband would turn in the night, my whole body would contract. So if I slept with my legs in butterfly, then I could actually sleep. It was definitely difficult, that scale she showed. I was, I don't have contractures that I know of, but I was the one below that. It was difficult for people to move my legs. It was frustrating for people helping me. I wasn't able to dress myself, coming like from able-bodied, competent person to unable to put on my pants. I just kind of gave up, because I was like, this is so, my body is fighting. People were helping me put on my pants and things. I needed help in the washroom. I had to put my legs on a block. So I'd put my legs on a block in front of my chair, and then I would catheter, like shift forward in my chair, but that would put me into extension. So my legs would kick out all over the place. And it would take me, I remember talking to some physiatrists and at some consults, and I'd say, like, it's taking me sometimes 45 minutes to do a catheter. Like, how is this not an urgent problem. Like it's hard for me to understand at that time why we weren't able to address it, or what my future was going to be like if it wasn't able to be addressed. So I eventually got a trial for a baclofen pump. So a physiatrist in Kelowna, I went into his office and I was trying to transfer onto his table, and my leg kicked out and nobody could put it back in for me to even transfer onto his table. And so at that point he referred me for a baclofen pump. And the way they do it is they trial, I think they usually do 50 milligrams. I could be wrong, but they did a dose to see how my body would react. And basically my body did not show softening or kind of relaxing within the typical time frame. So then I had to go home and then come back in a couple months for another trial. So meanwhile, it's taking me 45 minutes to go to the bathroom. People are frustrated trying to help me get my pants on. And I was thinking to myself, like, if anyone helping me, or if anyone had experienced this type of level of spasticity, one of the things that I'm thinking about is how I just didn't really understand how severe I was, honestly, because I kept thinking, okay, then maybe there's something wrong. So in hindsight, I would have loved somebody to say, like, you're a 10 out of 10 here. This really needs to get addressed. Actually, the person who did that for me was another person with a spinal cord injury who had a pump, and she came over and then she was watching my body, and she's like, oh, yours is way worse than mine was, and I needed a pump. So at that point, I think I realized, okay, I need to push for this. So what else? I tried lots of different things. I was stretching 2 times a day on the floor, and I would get about 30 to 45 minutes of relief. Stretching was effective, but it just wasn't effective for very long. And I started to watch war movies at night. I'm like a, rom-com type person. Prior to that, I work as a counselor, so I didn't like scary things, but I started just watching war movies every night or reading about war, which to me is kind of interesting. Like, it was like my body was just in this battle that I was trying to make it through. And I was working I was working 0.1. I was able to go back to work and not lose my job if I went back 0.1. So I did that, and it was tough, let me tell you. I was able to go out about once a day, and then I'd just be too tired. And I have 3 children too, so it was really tough for my family to watch. And they're hoping I'd get better, and I wasn't. So eventually, there was a 2-year wait list for the baclofen pump in British Columbia, and so I applied. I didn't realize this, but you can apply to get surgeries elsewhere. So I applied to get the surgery done in Ontario. I received a consult from an Ontario neurosurgeon, and they said, yes, you're a candidate for a pump. Why aren't you getting it done in BC? And I said, well, that's a really good question, because they just say they won't do it. They can't do it. And so I don't know what happened at that point, but eventually I think I had that consult in June, and sometime in August, I was called, like say maybe July or August, the neurosurgeon in BC called me, and I had the pump inserted, like surgery, in September of 2023. So 2 years after my injury. It was about 18 months that I was in that period, and it was really tough. I think I've been recovering from that. I also have a fair amount of nerve pain. I've realized after the spasms have reduced, so every time it would spasm, I just have more pain as a result of that spasm too. So very difficult. So I got the pump put in. I don't see any questions here, James. Do you?
Nope, nothing. Yeah,
okay. So I got the pump put in at VGH in September. I remember, because I was back up to the spinal ward where I had initially been. Some of the nurses knew me, and they ended up putting me up there. And I think my legs were in butterfly. No, they weren't in butterfly. So my legs were straight out in front of me, and I'm looking at them and I'm watching, and basically everything's quiet. My body has finally settle down. So basically right away, And they did double the dose of baclofen that they usually start people on, I guess. So they started me on about 100 milligrams, I think it is. And it was immediate. My body just settled. And so I asked my family and some people that are close to me, like, what did you notice about me after getting my pump? Because it's a little bit sometimes hard. Like my life is still, I would say, my life is still very hard, but it's more manageable. I've since decreased the dose slowly to, I think I'm at around 80 milligrams because like James said, spasticity can be really helpful. So I was too limp, for lack of a better word. So I've slowly decreased the dose. I've been able to work more. I'm working 0.6 as of right now. So that's quite a big difference. My husband tells me other people told him that it was more like the old Brita socially. That I think I was just really gritting my teeth basically to make it through life. Had more of a sense of humor. Just our family dynamic, the pressure lessened. I think it has had a big impact. I still like reading about war. I think that maybe just was going to continue for me. My daughter says that I can do more around the house and I have more energy. So that's good feedback. So I think, for me, it was quite a successful surgery and solution to a problem where nothing was really helping. So I think that's kind of it in a nutshell, James, but I'm open to saying more if you want.
For sure. No, thanks a lot, Brita. It's for those that I know that have the baclofen pumps, it has been a success for them. Obviously, a need. If the other, like medications and such, weren't working, that's for sure. I think one of the things that I really appreciate about the baclofen pump side is that it's targeted directly right at the spine. I tried the baclofen. I when I was young, first injured, about I'd say probably a year or so post injury. I thought it was a little bit prematurely prescribed, but I was taking a fairly low dose of the baclofen, and I started to notice depression issues. And the only thing I could relate the mood to was the medication that I had recently adopted. So as soon as I realized that I had, got off that medication, I noticed that my mood had changed and such. And I also realized that in my situation, the spasms weren't detrimental enough to my health that it required medication to begin with. But I mean, if you're getting spasms that are kicking you out of your chair and could cause, injury, that could be quite severe. And I think the other thing that you brought up there about, almost like something else being, like, it's not your body, it's not you, you don't have control of it. And I find a lot of people have a high level of frustration with spasms that they do get or tone that they do get. And sometimes, or in some strange cases, take it out on their body as well, which is, obviously not healthy, especially if you have, limited or no sensation on that level of your body. So yeah, many things to take into account, but trying to do everything that you can, like you did, prior to taking it to that next level is definitely the course of action. And if that's the way that it needs to go, the successes are high.
Yeah, for sure. I think, like you say, mood can come into play for many reasons. And I think, for me, it's hard to know with the baclofen orally, versus getting it through a pump because you're tired for many reasons after a spinal cord injury. So I didn't really notice a difference taking the baclofen myself. But I think that I've noticed somewhat of a shift in my mental energy and mental health following having the pump, just because I did not have the capacity to do much because so much was going into this war in my body is what it felt like. And nothing that I tried seemed to help it. So, I'm grateful. You're looking at some of those photos, it's just hard to, there's so many difficult situations out there. And then I remember the surgeon saying to me, like, well, the highest risk is that it won't work. I was like, yeah, that would not be good if it didn't work. So it did work for me. And so I'm grateful for that. And yeah, we'll see. Hopefully it continues to work.
Excellent. Excellent. It's like when you were talking about the war stories, I was like, yeah, I do watch a lot of documentaries on
Do you?
history, stuff like that. So maybe that's why I have no spasms. Is that what?
I don't know. I don't know.
No. But thank you very much, Rita, and thanks to everybody for joining us again on this session. Like I said earlier, we will post this, post the recording. We'll probably edit out a little bit there, just kind of compress it a smidge there in that technical difficulty. But we will share that. We will share the resources. Feel free to reach out to us with any questions. If we can support or we can help redirect to the resources and people to find the answers that you're needing, that's what we're here for. We are liaisons. So thank you very much again, Brita, and for everyone else joining. And hope to see you on the next session.